one of my colleagues said, "Hey, what about this meat diet?" And I'm like, "Are you crazy?" And for years I had problems myself with digestive issues, never had a flat stomach, always bloated. And the thing is, I said, anything I'm going to do for my patients, I'm going to try on myself. Treat your body well. Don't treat it like a trash can. When I go to conferences presenting, the biggest thing, the putting in the proof, man, what are you doing? You look great. You look amazing. You were a little puffy before. You looked great before, but now you look like amazing. What are you doing? Well, I'm eating carnivore and I only exercise 1 or 2 days a week. Are you kidding me? And I think that the more people see that, the more people get interested and then want to try it.
Okay, well, welcome everybody. I have a special in-studio guest with me. I've got Dr. Brenden Cochran with me. He is a neighbor. He lives out local to where I am here out in Snohomish, Washington. So he's just up the road from me a few miles away. So anyway, Brenden, welcome. Let me just go ahead and introduce yourself for people that haven't met you before.
Yeah, thank you for having me. So my name is Dr. Brenden Cochran. I'm a naturopathic medical doctor. Some people know what that is. Some people don't know what that is. I did my undergrad at University of Washington in chemistry and kind of felt like I wanted more tools for medicine than just basically medications and surgery. And I thought diet, biochemistry, all that stuff's really important being a chemist. So I got my graduate degree at Bastyr University there in Kenmore, did some rotations at the emergency med over in Evergreen, and did a fellow in integrative oncology. And currently, I have a lot of things I do. I have a primary practice in Linwood, Washington called Interactive Health Clinic. And then I also remotely practice with a doc in Deerfield, Illinois, in neuroscience, and also a few other clinics around the country that I work with remotely. And when I'm not seeing patients, I'm usually teaching doctors. I'm a busy guy. I like being busy.
Yeah, you mentioned that you do a lot of lecturing and stuff like that. And so let me ask you, how we came to meet was interesting. I had one of your patients that I interviewed as a success story, and she was put on a carnivore diet, I think by you, if I'm not mistaken, or you had helped her with that. Maybe you can touch on that a little bit.
Yeah, this patient came in to me and she had a diagnosis of ankylosing spondylitis. It was an autoimmune disease, was on several medications, flared up, and one of the recommendations I made in my clinical practice was carnivore diet because I'd been doing it for a while, had success myself personally, and started making recommendations. She was one of the many, I would say, that benefited from it greatly.
Yeah, and just full disclosure, Brent and I we both had big old nice 2-pound tomahawk ribeye steaks before we started, so we're doing good with that. We were walking and you were talking about some of the potential mechanisms by which this or other types of dietary interventions may work. Maybe you can discuss a little bit about the gut and how you perceive the gut, and why do we think we're having some success with removing what would otherwise be considered healthy foods like fruits and vegetables to some degree. What do you think is going on potentially?
The whole reason I went on it is I think I heard you and another guy, and one of my colleagues said, "Hey, what about this meat diet?" And I'm like, "Are you crazy?" And for years I had problems myself with digestive issues, never had a flat stomach, always bloated. And the thing is, I said, anything I'm going to do for my patients, I'm going to try on myself. And so I tried all these other different diets, and really after that 3-4 week adaptation phase, the constipation, diarrhea, everything that people are talking about, it was great. No pain, flat stomach, even being able to tolerate more foods. And one of the things we were talking about, and I see this in literature a lot, is we're starting to question, is more fiber or more prebiotics, more probiotics necessarily a good thing? And I think it was you that maybe pulled up a trial not too long ago that said maybe some of this fiber is actually increasing the risk of colon cancer in people. And I think what we're doing as a society where everything's got to have fiber or prebiotics or probiotics is actually making people worse, because we're overfeeding their bacteria, we're overfeeding the weeds. And so many people are getting autoimmune diseases, cardiac, chronic diseases. And we know 80-85% of your immune system's in that gut. So if you're fueling that gut and having that thing blow up, you're going to have disease processes. And I would say most of the patients I see, that it's very rarely that they're not having a digestive upset issue. And most of them are either it's a fungal like candida, or they have something like small intestinal bacterial overgrowth. And it's literally dumping fertilizer on a fire is what I see. in those patients.
Yeah, no doubt. I think the gut is a root cause or the common pathway for most of the chronic disease we see, whether autoimmune disease or even mental health disorders, things like that. So as you mentioned, with being a naturopath, you have many roles, you wear many hats, and you said something about neuroscience, and I'm interested how that sort of the interplay between what you're doing and I guess the mental health side of neuroscience. I guess for people that aren't aware too much about what naturopaths do, what is the purview? What kind of things are you suited up for treating? Is it pretty much all chronic disease, or what kind of things are you sort of mostly focusing on?
I think there's two areas of medicine that I like to tell people that we focus in. One is it's active or reactive healthcare. It's that chronic disease milieu of, I've been to 14, 15 different specialists and I'd never get an answer. Those are the people that we attract a lot. The other is proactive medicine. These are people that are trying to improve their health. And that's different than preventative medicine, where we're doing screenings or doing things to prevent negative things. Proactive is more, I want to live longer. I want to be healthier. I want to have more energy. So most of the patients that we see are usually not getting an answer with that standard equation of, hey, I got this problem, take this. And I would say medicine's starting to shift more and more towards, we call it functional medicine. The problem is, as you've probably seen, is it really hasn't changed that much. We just went from prescribing medication to prescribing the heck out of supplements for symptoms, right? But we're not addressing root cause issues. And I think dietarily is a huge root cause issue. We know when that gut's on fire, so your brain's on fire. And so one of the things that I'm passionate about in Chicago, the neuroscience, we can actually do SPECT scans of people's brains and see that they're lit up. And a lot of that, when we dig deep and we figure out what are some of the causations, it's got to be nutrients and how their digestive system's focused.
Yeah, interesting. And again, part of it's my own ignorance because I don't know a lot about naturopathy, but you think about it as somebody's going to hear some herbs and spices and things like that. But you're talking about SPECT scans, which are obviously very high-end, high-tech type stuff that you have access to. So it's interesting to see that. Now, you'd mentioned that at least in the world of the naturopathic world, there still is this bias towards kind of plant-based. Is that fair to say? And you're obviously going against the grain in that career path.
I would totally agree with you. When we go to school, we're taught eat lots of vegetables, high fiber diet, and even the cafeteria is mostly plant-based. The problem is with that is if you don't know better, I'm going through school, my brain's foggy, you're bloated all the time, you're wondering why your stomach's hurting all the time. And that message is still conveyed out there. And there's a large group of us that still focus on that. The other group, though, there is some of us out there that are now learning and getting educated by people like yourself that, hey, we're doing this wrong. And in medicine, we have that history of always trying to say this is the right way, and then we quickly figure out, oh, this is wrong. And so I think I stand out in that aspect. I also think, like in medicine with any practitioner, we all have our different specialties. I like to say, I do what's best for my patient. It's outcome-based medicine. So I work with conventional and alternative things. I'll prescribe medications if it's required. I'll send a person for surgery. I'll do some pretty high-end testing for a person. Mainly, I just want to get answers for that patient because it's about the outcomes. It's not about the...
Yeah, we talk about evidence-based medicine, but it really should be outcome-based medicine because a lot of the evidence that we rely upon is maybe not the best evidence, quite honestly. It's interesting to see how that paradigm has shifted a little bit. So since you did your own experiment, found the carnivore diet was indeed helpful, at least for yourself, and now you've started to employ that in certain cases in your practice. What contrast, like if somebody came up with a particular condition, you say, yeah, well, put yourself on a carnivore diet. That's clearly the right answer. 5 years ago, what would you have told that person? How have you evolved?
5 years ago, we were dabbling with ketogenic diet a little bit. So I'd recommend that slightly to people. A lot of the times it was your basic rounded diet, Mediterranean, eat nuts, oils, fish, lots of vegetables. And to be honest, when anybody comes in and they got a lot of bloating, a lot of dysbiosis, I give them two ways because I try to give patients options. I say the fastest way you're going to get an answer is if you go carnivore. I guarantee 4 to 6 weeks, this dysbiosis issue will be gone. Your stomach will no longer hurt. I've seen people with even gastroparesis that does not have diabetes just because of the overgrowth totally reverse those things using a carnivore diet, which blows my mind because, again, everything in science says, oh, you got to eat fiber all the time or you're going to get cancer or some other disease. But clinically, when you see people that are eating more of those things, or eating especially the processed stuff, all the fake fibers and stuff that we add to foods, their health is worse. Their mental health is worse. Their cardiovascular health is worse. And they're consuming so much sugar that they're getting diabetes or cancers or all these chronic diseases are popping up. And one thing I'll add to that is when people come in, they always want a pill. They think if you don't give them a pill, you didn't do your job. But I know deep down that it's not going to fix their problem. That's what a supplement and a medication is, to complement or simply supplement a deficiency. It's not a fix root cause issue.
Yeah, I wholeheartedly agree with that. And it's interesting you mentioned about the added fibers, because we see you go to the grocery store and it'll proudly display on the very front of the label 16 grams of fiber per serving or some ridiculous amount. And it's often basically wood pulp. They put methyl cellulose and stuff, which is more or less sawdust. And we have this stuff that we're like, what am I, a beaver now or something like that? It's just like, how do I even process this stuff? People that seek me out specifically seek me out because they know they want to do a carnivore diet. People that seek you out perhaps still have they want to get healthier and they're not maybe focusing specifically on that way. So how often do you have success in saying, hey, this is what I think you should do with diet, maybe a carnivore diet, versus what percentage of the population is open to that in your practice?
I'd say right now, until the word's starting to get out, so more and more people have heard of it, but they're not necessarily ready to cross that boundary. Or the other thing I see commonly is people have dabbled, but they don't know enough to get through the first week or two of that transition phase. Your body has to adapt to fats and hydrochloric acid and all this die-off that's going on. So I'd say in my current practice, I'd say about 40% of people have heard of it or have heard of like a ketogenic diet. When you bring it up to them though, most of them look at you like you're crazy still. And I'll tell them, sometimes it might take 4 or 5 visits of them suffering and, okay, I'm going to prescribe you a pill or do this and we'll try this. It's still not getting better. And then finally it's like the light bulb cracks or I'm desperate. I'll try anything. Okay, great. Well, this is one thing I've been telling you that you need to try. And finally they'll try it. And I'll say, hey, it may be rough for you for about 3 or 4 weeks. And then after that, things get better. Just depends how much chaos we have going on in your gut. I've had people 1-2 weeks, they're fine. And then other people get those 3, 4, 6 weeks. And you usually know who those are. Those are the ones that are getting bloating and gas and nausea and the pot belly-like issues.
Yeah, let me go back to a topic we were discussing over lunch about glyphosate, because glyphosate, as everybody is probably aware, many people are, that's the herbicide found in the trade name Roundup, and it has made its way into our entire food supply. You'd mentioned that you see a lot of patients with high levels of glyphosate in your urine. Can you talk about what's going on there?
Yeah, so one of the trends I put together since recommending carnivore diet and paying more attention to it is glyphosate we can test with urine pretty easily. We just do a random urine sample, send it off. There's many different companies that will do that these days. Like clockwork, people who are eating a lot of grains or drinking alcohols with a lot of grain-based, or they're juicing, even juicing organic. I've heard that. You've probably heard that too. Oh, I juice organic. It's got to be fine. You still test their urine and you can't control the crops around there. So it's drifting into the crop itself. When you juice, what are you doing? You removed anything that's binding up that glyphosate. So it's just concentrated glyphosate with everything else that might be irritating your intestines, like the oxalates and salicylates and everything else that's poisonous as well.
Yeah, interesting. There was a study that Canada had produced on foods, and they were looking at different glyphosate residues in different foods, and they found that, number one, grains and legumes had the highest concentrations, and like fruits and vegetables in the middle, and then meat, milk, things like that. Animal products had basically essentially zero. Have you ever done like a urine glyphosate screen on someone pre and post carnivore? I'm just wondering if you've been able to do that.
I'm doing that more often. I've done it myself and I've seen the change, but on patients, it's capturing them. And I would say I'm seeing a curve. It's probably not enough to say I can publish a study on it yet, but I would like to get that data. It's basically glyphosates. The other thing I see in grains is your mycotoxins too, your molds, right? Moldy grains. You don't get that in beef. I think definitely we're going to see this trend of improvement. And if you're removing Roundup that's sitting in your intestines, because why is it there? Well, if you look at how it's absorbed, your body mistakenly thinks it's glycine. And so it absorbs glyphosate thinking it's glycine, which is an amino acid that we commonly use. It's 2/3 of your collagen, right, is glycine. And your body just absorbs that, sits in your intestines, and it does the same thing it's doing for insects or weeds, is killing everything off in the gut, making that leaky. And then we wonder why everybody has anxiety or depression. Well, the gut's inflamed. Guess what else is inflamed? The brain.
Yeah, that was one of the, I guess, criticisms of the fact that one of the reasons glyphosate was supposedly chosen, we lack some of the enzyme capacities that make it problematic for mammals. And this is why it doesn't accumulate in meat and things like cows. But it has a pretty dramatic effect on our microbiome. And as many of us are learning now, that the health of the microbiome has an impact on our overall health. And as you mentioned, leaky gut or hyperpermeability of the gut. So that is quite an interesting thing. Let me ask you because I come from conventional medicine, even though orthopedic surgeon, we're not that lab focused, but the traditional labs, CBC, basic metabolic panel, lipid panel, what type of tools do you like to use in your practice and for what conditions?
A few of them. So anybody comes into my office, I'm thinking about metabolic terrain. Are they metabolically flexible, right? One of the cheapest ones we can do, you probably heard of, is LDH. It's like a $5 test, right? That LDH tells you if you're consuming way too much glucose and carbohydrates. The other thing it tells you is you're not getting enough oxygen to those cells. It basically is telling me this patient in front of me is fermenting like a beer can versus they're actually getting proper oxygen and doing proper metabolism. I can run that. If anybody's over 175 on there, I know there's problems. And if that's high, you're setting up a terrain, your garden's already planted for cancer or cardiovascular disease. And I do this commonly with my integrative oncology patients and my metabolically inflexible patients. I'll run that lab, gives me a lot of information. I do use fasting insulin levels. I do use something called MMP9. MMP9 is actually a connective tissue inflammation marker. And usually I will see that elevated with gut inflammation or histamine issues in people. And I can track that based on when they're improving, I can use that variable. So that's some basic labs that I think we commonly can run through a common blood draw lab. Then there's more specific labs you can do that run nutrient profiles. And then you get into things that I like to test in the office. So one is, you've probably heard of body impedance. I put a person on the scale. Yeah, it's super cool if you want to see what your body mass is. But for me, I really want to know what is the intracellular water versus the extracellular water. Because if that's not a 3-to-2 ratio and most of that water is extracellular, you got a lot of inflammation. You got some very unhealthy cells going on there. And I can see it. When they walk in the door, you see that mixed edema, puffiness all over. They got the baggy eyes under them. But they need to see that on a piece of paper. So we put them on a scale, it prints it out. It's a pretty looking diagram. And then I can tell them, hey, this is a problem right now that we got. So those are some simple things we got in our office. There's a couple other things we use that are not as conventional, but I find them helpful in like terrain markers. The whole thing is terrain. It's treat your body well. Don't treat it like a trash can.
Yeah, exactly. I've said that before. Don't treat your body like a trash can. A lot of us do. And it's interesting because we know there are diseases. Some of them are infectious diseases. We have a whole host of non-communicable diseases, all the diabetes, heart disease. Even when it comes to infections, whether it's a respiratory virus or a bacterial infection, the host does have a big role there. If your host is compromised, you're going to be more susceptible to all kinds of things. And what, I guess, the folks that come to see you, what are some of the more common diagnoses that you usually see? Is it the common things, diabetes, hypertension, or do you see a little bit more of a kind of a varied clientele?
So it used to be more generalized, but since I've been practicing for a little over 13 years now, my name's gotten out for integrative oncology. So I see people across the country, across the world is one of my focuses. How do I synergize and make the person do better while they're doing their conventional therapies, get better outcomes? Then we see this milieu of, like you said, it could be a diabetic patient. Those are simple patients. Okay, change their diet, get them eating better, maybe work on some hormone stuff, get them moving their body because their lymphatics is like a trash can, like you said, because they're not moving. those people still come and see me. But to be honest, most of the people that I'm typically seeing now are usually the train wrecks where they have pain, weird neuropathies that they've gone through the milieu of testing. Like they've had EEGs, EMGs, they've had every single thing you can think of, and they just can't give them an answer. So it's either let's put you on immune suppressants or put you on steroids and see if that works. And you and I know that's not a great answer long term. So most of the people are in that category. And once they're told you need to go see the psychologist for this pain issue, usually, unfortunately, I ended up seeing them because they know it's not a mental problem. It's a physiological issue that's going on.
Yeah, and you'd mentioned that you do dabble, or you do have part of your practice focuses in kind of chronic pain patients, which are tough patients. And a lot of chronic pain, a lot of times they've been through the ringer, and and a lot of times eventually it's like, here, take some antidepressants, it's in your head, just accept it or something along those lines. And so how are you evaluating these chronic pain patients, and then how do you try to get them better?
Yeah, so in our practice, we either have the 4-quadrant pain system. 4-quadrant pain is pretty much what I just talked about. It's a metabolic inflexibility, or they commonly will have bugs, Lyme, mold, candida. And the thing is that's very interesting about candida or overgrowth, you did that, right? Yeah, maybe you were given too many antibiotics and it threw off your gut biome, but most of these people that come in that don't have that history, you can see it's because they drink like a fish, they eat all this processed sugar stuff. They literally were pouring gasoline on the dandelion, or I should say fertilizer on the dandelion, trying to get that thing to grow. And then they wonder why it's there. So that's one of the areas that we commonly see that contributes to pain, is dealing with that overall inflammation. If you're looking at specific pain, which people do come and see me, like low back pain or shoulder pain, knee pain, ankle pain, they're looking for different answers than just a steroid shot or immediately going into surgery. I'll give you one example. Somebody came in, they had an x-ray and they're told, oh, you got to do a total hip replacement. Whoa, you got rheumatoid arthritis. We haven't looked at anything else yet. We're still working on your gut profile. We were cleaning up your diet just like within the last month. Let's not jump to that. Do you have an MRI? No, they haven't done an MRI. They haven't done any of that. Well, this is a big procedure. We should look at other options. So we get their labs back and their gut is just terrible. It's terribly inflamed. They got fungal overgrowth. They got all these things going on, and you got to get control of that. Otherwise, their pain's not going to go away. And if they do surgery, you probably know better than I do, they're not going to recover as well if they're having all these other issues. So that's one of the areas we focus on.
Yeah, most decisions to do, whether it's a total knee or a total hip, are basically made on x-rays. We typically don't get MRIs because you can usually see there's so much joint narrowing and you don't really need the addition because the MRI is going to show worn cartilage is gone and the meniscus is trash and all that stuff. But having said that, I've seen a lot of people who radiographically, I literally had on the OR schedule, like, clearly you need a knee replacement. And then just by luck, at this time I was saying, hey, let's try a diet, make you lose some weight for surgery. Their pain went away. And we ended up canceling their surgery because you're right, there are things that can be done prior to. Sometimes still people progress to a surgery, but and you're absolutely right. If they're a metabolic wreck, their guts are wrecked, their nutrition is a wreck, they're going to be much more likely to develop complications post-surgery. They're not going to heal as well. They're going to have more pain in the post-op recovery period. Their range of motion is going to be compromised because of the pain and the swelling. And so absolutely, it makes sense. Particularly, like you mentioned RA, rheumatoid arthritis, which autoimmune disease, clearly gut has a dramatic impact on there. How do we assess gut health? You mentioned LDH and some of the other things. Are there any other specific? Does the microbiome help? Are there any other good gut health tests?
Yes, I know a lot of the answers, which is great. Medicine has progressed. Now, if you go to a gastroenterologist, you actually hear the term probiotics, where years ago you didn't. Problem is most people still don't know how to prescribe those probiotics, so they understand them. And so they think that's the fix. But I know you and I were talking about this. Most of those probiotics, they actually increase something called D-lactate, which is neuroinflammatory. And that's one of the reasons people get more pain or more histamine, more issues, is they're taking the wrong probiotic or they're overdosing it. So a lot of people just jump to conclusions and do that. Now, you can diagnose good clinical skills. If you see a patient coming in and their classical symptoms are bloating up, it gets worse as the day goes on when I eat more and more things. That's probably there's fermentation going on. And we call it SIBO, small intestinal bacterial overgrowth. But if we want to get actually clinical diagnosis, we usually do what's called a breath test if you want to clinically confirm they have SIBO, or you can do a PCR or a very thorough gut biome test where it looks for PCR or culturing of different bacteria and funguses, and if there is anything else in there. The other thing that's nice in there, a lot of them these days, they put in like antigliadin, they'll put in calprotectin, which are an inflammatory marker, plus are you reacting to gluten? And I think you touched on a lot of these people, they have that antigliadin because they're eating something that has a lot of glyphosate in it and they're overeating it, and that's causing this immune reaction in their gut. Because one of the things I think is fascinating is you have patients that go overseas to like Europe, they can get away with eating the gluten products over there. They don't have their gut be a trash. They come back here and they think, oh, maybe it was a coincidence, I'm getting better. It just wrecks them.
Yeah, it's just funny. My significant other, she's from France, and she used to say, I can eat bread in France, but I can't eat it in the U.S. And so obviously, clearly there are some differences. And interestingly, I think there's like hundreds, if not more, maybe thousands of food additives that are illegal in Europe, which we consume by the millions of pounds here in the United States, which is a little bit concerning. Tell me a little bit with regard to the sort of the genesis of the naturopathic doctor. Where did that come from? We know where I came from, allopathic medicine, it was this so-called Flexner report and the Rockefeller type of thing. And we've got a certain way of doing it. We heavily utilize pharmaceuticals more so now than ever before. And there's a very certain kind of a narrow path we walk upon, but there's all these sort of alternative or complementary medical things that are often almost looked down upon by a lot of people. However, there's a lot of people doing a lot of good out there. So what is naturopathic? Where did it come from, and how has it progressed? And I guess there's subspecialties within that, correct? And you practice one of those. So give me a little overview of that.
Yeah, so you were commenting on the Flexner report, right? And basically back then what happened is you had two groups. One was practicing more based on antibiotics, drugs were up and coming, surgeries were up and coming. We were talking about bloodletting even back then as a procedure, right? Then you had this other group that was more terrain focused. And we still do that today. It's if you take a goldfish and put it in a dirty tank and you try to give it drugs or give it things, is it going to get well? Absolutely not. You got to clean the tank, right? So there was this group of docs, they're medical doctors, that literally said, well, we don't think this is the right way to go. We think it's more basically healthy terrain theory. So the evolution of the naturopathic doctor came from medical doctors actually back then. And with that evolution, they eventually designated themselves as a naturopathic doctor, or some states are naturopathic medical doctors, depending on what your board is covering. And that's what came of it. Now, there's different tools that we use. And I think a designation in clinical medicine, I don't think a designation is necessarily a great way to do things. It's like when you're in a designation, it's what is the tools and the subset of tools that you're utilizing. Because I have practitioners who are medical doctors, NDs, chiropractors, and they're really good at what they do and they can think outside the box. And then there's others that are very like one-sided, like it only has to be natural or it only has to be conventional. And the bottom line is why? With the more tools we have, and what we've seen in medicine is we often start innovation by clinical observation, right? And then we end up getting to studies, like with diet changes, with IV therapy, ozone therapy, which I do in my practice. They start with clinical observation, and then we eventually go to a larger research trial.
Are there differences by states in with regard to the scope of practice for naturopaths? I think there is, but maybe you can expand upon that.
Yeah, so there is. So I'm currently licensed in Washington, California, Idaho, Montana, and working on my Arizona license. And it's all different. So if you're in Arizona, you have to have a controlled substance training because you can prescribe controlled substance. Now, some of us are like, I don't want that responsibility, and I totally get that. In Washington State, it's a very open scope. You are controlled on certain controlled substances. Like we can prescribe testosterone, for example. I don't really want the narcotics because unfortunately you get those patients in your office that are looking for that, and I have other tools I can use. So I don't want that. But otherwise it's pretty open. We can order things like I commonly will order coronary angiography CTs to see plumbing issues with people. I'll do some very innovative tests to see, is my treatment working? And I think that's the biggest thing is, can we do a medically approved test that is confirming what we're doing and getting results? And I think the people that get in trouble in the natural or conventional is just take this and you're going to be on it for the rest of your life. And then let's not change that is a big issue. Each state, we have different tools. And then each state, we have comfort levels. Like I feel very comfortable managing medications. I've done it for a long time, chemistry background. We had to take pharmacology. I teach lots of pharmacology classes. Idaho is an NMD, just like Arizona. And your actual board is controlled by the medical doctors, the DOs. You're under the same board as them. So each state sets their regulations. And it is really helpful that we do have licensing, because if you go to an unlicensed state, you have a person who can call themselves anything they want and have a weekend of training. And it could be a harmful thing because they have not gotten an undergrad degree. They have no medical training. They had no board exams. They don't require CME or certain trainings to be board certified. They don't have any of that. And that can be dangerous. And then unfortunately what happens is, oh, I saw this person who was an ND. Well, were they really? They weren't in a licensed state, so we don't really know. So that's how it goes right now. Is it's growing in licensure, but the states that allow the most are usually on the West Coast.
So you can both de-prescribe and prescribe medications in the state of Washington and Idaho, same as an MD could, basically. Is that correct?
Correct. Yep.
Interesting. I didn't know that. So that's interesting.
And the thing I'll add to that is it's very, and you probably see this too, is a lot of the times, especially like the newer grads these days, I know how to prescribe things better than they know how to do it. And most of it's for clinical experience and trainings and stuff. And so we can use that as a tool. I do use that as a tool. I don't like to leave people on it. It's simply that. I got to stabilize this patient. Otherwise, they're going to have something really bad happen to them. I'm using that as a tool.
You mentioned that sometimes you'll order cardiac angiography to see if your interventions are helpful. What kind of interventions and what are you trying to do? Are you seeing cardiac angiographies usually looking for stenosis or some degree of plaque formation? Is that something you're investigating and having an impact on?
Yeah, so cardiovascular disease, a coronary calcium score is a really cheap, effective way to see what your calcification score is. If I see that high, like I had one last year, it was 0. That's great. That means I don't have anything getting in there, and I'm carnivore, like we talked about on this show.
But you're only 40, so you don't expect anything more than a 0 at 40.
Well,
but
I hope not, right?
Yeah, right?
Some people you test though, and they're higher than that. Sure. And to be honest, most of those people are the ones who are eating that junk diet, overweight. They're terrible, right? So most of these people they're already diabetic. They got all these risk factors. Their lipids are through the roof. They're eating crappy. I'll usually start off with a cheap test, coronary CT. Okay, wow, 400, 600, 800. You're only 45, 50. I need something a little more interventional. So I'll send out, and there's not a lot of places that do it. Actually, there's one place here in Bellevue that's a specialist radiologist that does these. I can't even order them through the big hospitals here. So she does it, and then it gets sent off to an AI platform. And the AI platform does this nice 3D modeling, so we can see every single vessel and see what the soft plaquing is. Now, the cool thing about this is I can get more precise information about what's going on there. And then we can see, is our interventions helping? Should they be on something like a medication, or do they need to be punted off to our cardiologist to get a stent because they're going to have a heart attack right away? But the other thing we're exploring, I don't know yet, I'm hoping for, is if you've ever looked at TAC1 trial was published, about 6-7 years ago. TAC1 was trying to disprove that chelation therapy had any benefit from a cardiovascular standpoint. And the worst thing is they did nothing for these groups. They were diabetic, they're smoking, they're eating crap. They did no low carb, keto, carnivore. All they did was chelation. All of those patients noticed cardiovascular benefit. And that was surprising because they went after the trial, NIH funded, to disprove chelation has no benefit for cardiovascular disease. Currently, there's TAC2. Over 25,000 people, multiple locations, is being published in 2024. To show, was this a coincidence with 900 people or was this not? The thing I know from the principal investigators at different locations that I know, they said it will be promising. What we saw at our site was very promising. And know that these are just people that are not doing any other change. Imagine if you put them on a carnivore diet or a low carb diet, how much more change they would do along with that. And I think we forget that in medicine. We just think it's one thing that will do everything. When we approach a patient, the more tools we have, the better outcomes we get.
Yeah. And within your patients, and since you have access to coronary calcium scans, cardiac angiography, are you seeing, well, what are your thoughts on there is this, I guess, LDL ApoB hypothesis? Some people would say it's a clear fact. If you talk to a lot of conventionally trained cardiologists, they'll say it's undisputable that elevated ApoB is the elephant in the room for heart disease, and everything else is irrelevant for that. Is that what you're seeing on the ground? Is that what you think? Or what does your experience and training tell you?
Yeah, everybody talks about ApoB-A1 ratio is really critical. If it's elevated, you got a risk that something's happening. But I think we have better tests than that. And I think that most in the carnivore community, we all will find that we run high. When I went on it, it went high for about 6 months, and then it actually went down, which was super cool. But we have other tests, like you can do an MPO. You can do an oxidative LDL too. You can use these calcium CTs and angiography tests now. And I think that the lipid theory is probably the lowest of all. And if I look at, I think there was a paper published on cardiovascular disease about 5-6 years ago that looked at all risk for cardiovascular disease. And it pretty much said obesity was number one. And then it talked about diabetes. And then triglycerides were much larger risk than you having elevated lipids like LDL or ApoB to A1. That it was like a small sliver. It was like 3 to 5%, if I remember that study. And I believe that we have so much focus on just that one number, we're missing out on all the other things, the inflammation and the diabetes facts that are more important.
Yeah, there was the Women's Health Initiative study, I believe, or Women's Health Study, one of the two, actually published in January 2021, showed, again, the same thing you're pointing out. I think in that study, actually, diabetes was the greatest risk factor. Then it was metabolic syndrome, and then obesity and smoking and family history and triglycerides. And towards the bottom of that strength of risk was LDL cholesterol and ApoB and stuff like that. So that's clearly, there's evidence to show that there's maybe bigger fish to fry than driving everybody's LDL down to the basement, which some people are advocates of. What else am I going to ask here? What do you find as far as, I guess, again, specific to the carnivore diet, are there patients where you're like, this is clearly appropriate for them, and some other ones where like, maybe we'll wait on that? But are there ones where like, this would be a slam dunk for carnivore? Like, I usually see it with like ulcerative colitis, Crohn's disease. I think that should be the default treatment as far as I'm concerned. But do you see any particular patterns that would say this is going to really respond well to this particular intervention?
I think anybody with a GI issue, I agree 100% with you. GI autoimmune disease, I think, is huge. Any other autoimmune disease, I think, is also huge as well. When we get into other classifications, I think pain, orthopedic pain, if you're trying to get them better and see if it's functional or not, because you and I know you can have people with terrible MRIs, they have no pain. And so there's a lot more players to it. So I think pain is huge. I see people's pain levels cut way down when they're put on a carnivore diet. And then the other one I'd say is anybody, obviously metabolic syndrome, or even, and I'm going to go against the grain here, is even people with cancer. What's fueling the cancer? It's those glucose levels, right? Blood sugar is dumping fuel on a fire there. So even in cancer, in certain cases, the only one I have some hesitancy about still, and I think I'm waiting for more data, is what do we do with say an active prostate cancer? That would be the controversial one. Don't put a prostate cancer patient on keto or carnivore. At least that's what's going on. And that's one of those areas I think I'm still dancing around, that I might be a little more off. But I think far and large, everyone else, if they're willing to do it and they can stomach it, it's definitely worth it. The most difficult patients I get, and you probably see these days, is the ones who have been raised on crap foods and their palate just, they don't want to change anything. And I can't do anything for that person if they won't make that change. And I don't know what to do with those individuals.
Yeah, it's definitely, you've got a whole food industry that's dedicated to creating these hyper palatable foods that are not only addictive, they taste good, but nutritionally more or less devoid and actually harming us. And yeah, it's tough getting them off of that. How many, just to get a feel for how much you're, like in your, I know you do a lot of online stuff, but in your like day-to-day practice, what's the volume like? Are you seeing 10 patients a day, 20 patients a day? What does it typically look like?
Yeah. So typically for my practice right now, I'm in the office about 3 days a week. The reason I do that is I'm doing a lot of other things, teaching other doctors and consulting and coaching and stuff of that sort as well. But typically a day for me looks like about 9 to 10 people. It's not a rushed visit. And the reason for that is I got to understand what's going on with that person and educate that person on what's doing. I can't do that in 5 minutes with a chronic disease. They come in with the list of 15 different things. You're not accomplishing anything in 5 minutes other than prescribing a drug and sending them out the door. And they're not going to get well. And I think one of the benefits, I would say, I've had colleagues, physician's assistants or medical docs who are trapped in that system, the big hospital system. I won't name names, but literally I've had some go into it. They took their signing bonus and they basically gave it back to them and said, hey, this is slave labor. I'm being asked to see this many people in this amount of time, and all I can do is throw things at them, and they never get better. And I think we need to change that.
Yeah, I can remember as an orthopedic surgeon routinely having 45, 50 patients on the schedule. Plus I'd be seeing some of my PA's patients because they needed help. And sometimes you're touching 60 people a day and the quality of your care is clearly not as good as it could be or should be. And I think that is the modern healthcare system. And doctors have found that the only way they can make the income expectations they might have had is by seeing vast quantities of patients. And again, that's just substandard care for sure. And I'm almost ashamed to say I was part of that for many years, but that's just the way the system has become. I think I see a year into Carnivore yourself or something like that. Do you see, and you're interacting with a lot of other healthcare providers, whether they're naturopaths or other specialties, do you see any inroads, more people waking up and getting it? Or do you see it still pretty much all upstream?
Yeah, I'm a little over a year and a half now. And when I go to conferences, I think we were talking about this a little bit, but it's very interesting. I'm going there presenting. We got the cafeteria, and it depends on some of these cafeterias you go to that are functional med. It looks like healthy stuff, fruits, vegetables, all that stuff on there. It's not donuts and orange juice like the conventional groups that I'll go to. And they'll look at you funny because you're the one that's picking the chicken or the steak off the plate, and that's all you're eating. And then there's usually a couple people, though, in the audience. Oh, you're on Carnivore. So it's getting out there. It's getting more well-known. The biggest thing, the putting in the proof, man, what are you doing? You look great. Literally, when I went on it, it's like I went back down to my high school weight, leaned out. It's great. The inflammation went off when I did that. And people comment on that. What are you doing? And that's what got me intrigued. I saw one of my colleagues doing it. I said, you look amazing. You were a little puffy before. You looked great before, but now you look like amazing. What are you doing? Well, I'm eating carnivore and I only exercise 1 or 2 days a week. Are you kidding me? And I think that the more people see that, the more people get interested and then want to try it.
How much, you mentioned you lost, how much weight did you end up losing?
So my top weight, I've never been a heavy guy. I've always been this kind of lean guy. But the problem is with me is I've always had the belly issue, like a little bit of that pudge on me, no matter how hard I exercised or not. So I would say I was pushing 198, 200 at my highest. And then my normal weight for me, a good weight for me is pushing around 180, 178-ish range, maybe 185 if I'm really hitting the gym hard and being good about that. But so you're talking 15, 20 pounds, which for me is a big deal. I know people lose a lot more than that, but that much weight, you notice it and people notice it.
Yeah, and you can see it in like your face. A lot of times you just, like you said, you mentioned you have this sort of puffy visage, your whole face is swollen and you can see that pretty quickly. A lot of times that goes away very fast.
Yeah, exactly. So I have my patients on it. And then actually personally, I put my mom on it recently. She's a late onset type 1 diabetic. Everything that's against the American Diabetes Association, they say, oh yeah, eat carbs and cover it with insulin. So to give you an example of her being on it for a month, so her fast-acting insulin went from 14 units a day to 4 units a day. That is remarkable. And she's not a terrible diabetic. She's lean, she moves, she exercises, she watches what she eats. But I say, hey, try this. And she's done that and she's got her insulin down that much. And I think that's incredible because you and I know insulin It's like the child that doesn't have a task. They're drawing on your walls or sanding your walls or stuff. It's very destructive if it's floating around in the system and doesn't have a task.
Yeah, that's, you think from 14 to it's a 70% reduction or something like that in the insulin requirement for rapid acting. You'd mentioned the American Diabetes Association. Is there a national naturopathic organization, and do they have any position statements on diseases like diabetes, or do they just parrot whatever the ADA says?
So there is the American Association of Naturopathic Doctors, and then each state usually has its associations too. I will tell you one of the things that is going on, which in my opinion, and some of my other colleagues have been out for a while, what we are seeing now, even in the schooling, is you're being trained as a primary care provider. So you're coming out and you're required to follow standard of care. I'm like, this doesn't make sense. You went to school to become a health expert, right? Not a primary care provider. So they're being now taught to prescribe antibiotics right off the bat for this, refer everything out. And I'm like, what's the difference between you coming out of school and a nurse practitioner that works at Walgreens? Which for me, it's like you went to school, you went this way to make a difference in their health. And so unfortunately, what we've seen in the career is it's gone that way where we have to conform and follow the standard regimen now. You can still use natural alternatives, but the art that's being lost in all medicine, and I see it in naturopaths, chiropractors, even the medical doctors. One medical doctor told me it's a liability now to touch your patients, is what they're teaching in one of the schools in Colorado, I believe. And I'm like, oh, that's crazy. So we're losing that diagnostic skill and that thought process of actually investigating and breaking down what we learned in school. Instead, we're learning just a protocol and standardized everything.
Yeah, it's interesting to think. I can see, well, why would I touch a patient when I can do a CT scan or an MRI or something like that and see everything? I don't need to palpate the guy's liver. He's an orthopedic surgeon. Like the standard knee exam was inviting. You could put your hands on and move the knee around, see if the ACL was torn or elicit pain and things like that. So you could avoid some of that imaging, or you might be directed to further imaging later, but to think that's going on. So is there almost like there's becoming a corporate capture across the board? Allopathic medicine has clearly been a victim of corporate capture, whether it's big healthcare systems or pharmaceutical industry. And it seems like maybe even within the naturopathic field, you're starting to see a bit of that. Is that correct?
Yeah, I would agree. And that's one of the arts that's being lost is that it's feeling like you have to do standard of care. I'm not saying standard care is a bad thing. When I educate a patient, that's my job, is an educator. So I'm going to tell them this is the standard of care and these are other options. That's the appropriate way to do things. But if I'm just going to ram standard of care down there.
Yeah, I think one of the problems with standard of care is sometimes the results from standard of care are pretty suboptimal. And you're like, well, we're going to just ensure everybody gets suboptimal outcomes, whereas sometimes these other things actually have better outcomes. And because it doesn't align with whatever financial or corporate incentives are, you're stuck into that. And it's a catch-22 because a lot of physicians feel helpless. They violate the standard of care and then something does go wrong, then they're set up for liability. And so it's a tough sort of thing to tread across.
The interesting thing though, that I'll add to that is as this is happening in the naturopathic community, the conferences I lecture at where it's IVs, ozone, orthopedic stuff, more than ever, medical doctors, nurse practitioners are showing up at those conferences. They want out of that system. They want to do something on their own. So they're running away from it. But unfortunately, some of our profession is running towards it.
Yeah, it is interesting. A lot of physicians, some of them that realize, hey, what I've been doing and been taught for the last several decades just doesn't work very well. And a lot of them, I've personally, I'll take the blame. I've probably caused a number of physicians to give up their practices because they're like me, they couldn't ethically resolve continuing to see the 40, 50 patients a day and have minimal impact and sometimes actually doing harm. They just couldn't ethically resign themselves to that. And so they said, I'm just going to give up my practice and do online health coaching or some other thing. There's people, they're struggling with that, which is it's great that they're willing to do it, but it shouldn't be that way. You shouldn't have to go starve and put your family at risk because you want to do the right thing, which I think a lot of us have been in that position. What, as far as recent trends within the naturopathic world, You mentioned chelation therapy. I know you've talked about ozone therapy. You've talked about, a whole bunch of things. And I guess maybe inform me a little bit about the ozone therapy. I remember having a patient coming to me about 15 years ago talking about ozone. I thought he was nuts. I don't know how you're talking about, go away. I was an orthopedic guy, and he was telling me, I was like, I don't know anything about this. I think it sounds like snake oil. Yeah. Go away. What is that exactly? I know what ozone is, but what is it purported to do? And have you actually seen some benefits with it?
So yeah, ozone, the first time I got into it, because I'm a science guy, I came from a chemistry background, so I criticized the heck out of it. I said, this is cowboy medicine. This doesn't make any sense at all. And I dug into the papers that are available. And if you look at, there is a standardization. It's called the Madrid Declaration, International Madrid Declaration. There is an American Association of Ozone Therapy as well. And you can literally get every single research trial on ozone. Now, most of the research is the strongest in things like ischemia of different areas of the body. The other area is really orthopedics. So even paravertebral injections of ozone, which you think is crazy, provided pain relief. Osteoarthritis provides pain relief and improvement in function. How does that happen is what you ask. There's several papers now that have come out defining the mechanism of action and comparing that to Synvis, hyaluronic acid, PRP, et cetera. And what ends up happening when you inject it, it's not just oxygen. And we're talking medical grade ozone. We're not talking the pollution stuff or the stuff you get from your pool. Those are not medically grade. These things are medical equipment that basically you understand the exact concentration and you're comparing that with what literature exists. And there's 2 trials in the US. They're published one of them was in Medscape 2015 on NEOA. And it was pretty dramatic in WOMAC and VAS scores, and it was double blinded. It was a small group, but it did show significant benefit in those with mild to moderate NEOA. And they were doing it once a week for 8 weeks, and then they reobserved the patient after 16 weeks. What I see in my clinic is I see pain relief. Now, what is it mechanistically doing? If you actually look down into it, the papers are defining that you're getting reductions in uric acid, P levels. You're seeing it act as like a COX-2 regulator in there. And it's providing oxygen, but it's also improving antioxidants in the body. Just like when you go to the gym, if I give a tiny bit of an oxidative stress, like when you're working out at the gym trying to build your muscles, your body's going to compensate for that by increasing antioxidants. So you're training your body just like you train your muscles.
Interesting. Well, we've gone about an hour. This is usually how long I do these. Brenden, thank you so much. Tell me, because you do have an online presence, where do people either find you online if they wanted to use you as a provider, and locally if you're interested in sharing that?
Yeah. So locally, I'm at Interactive Health Clinic. It's in Linwood, Washington. I see patients from all over the country. I consult with people, and usually I have a bunch of different providers that are nurse practitioners, medical docs that I work with, interventional pain guys that commonly I'll work with in different states. So that's one way to get a hold of me. The other way is drbrendancochran.com, where usually I have all my trainings, my consulting information, who I am, what am I doing there, some of the podcasts I've been on, those types of issues.
Yeah, so Brenden, Brendan, and then Cochran, Cochrane, correct?
It's actually Bren.
Den, okay.
And then Cochran without the E at the end, yeah. Cochran.
Without the E?
Without the E.
Okay, because somebody sent it to me with the E.
I know.
I'm glad you clarified that, because I had it wrong.
Everybody spells that wrong, right? My name, I've gotten that all my life.
Okay, good. Awesome. Well, thanks. Hopefully the steak is digested, and this is great, and it's good meeting you. And it's good to have another carnivore advocate in the local area. Thanks so much for doing what you're doing. Appreciate it.
I appreciate it. Thank you.